Alright, we move on to renal, the complete renal review for the USMLE and shelf. Now, if you struggle with nephrology, then this video is absolutely amazing for you, because I covered everything you need to know in a really fun way. Let's begin. Here we have the heart, and here we have the kidney. It's actually kind of cool seeing them side by side like this. They're actually the same height, about 5 inches tall. But that's not why I brought them both here. The reason why I brought them both here is to make the following point. The heart supplies blood to the kidney. And as you can probably recall from your nephrology teacher,
the kidney gets about 20% of cardiac output.
Yes, indeed, the kidney gets 20% of cardiac output, meaning the heart pumps out 5 liters of blood every minute, and the kidneys get 1 of those liters. But this does not mean that GFR is a liter a minute. The nephrons are, of course, not filtering a liter a minute of blood. This merely means that the kidneys are supplied a liter of blood, but they're actually only filtering 0.12 liters of blood a minute, or 120 milliliters of blood a minute, and this is what GFR is. I hope we didn't insult our nephrology teacher with this information. Let's tell him 2 nephrology jokes to make him happy. What do nephrologists say to non-compliant patients? You're in trouble. What happens to nephrologists who smoke marijuana? They get kidney stoned. With that introduction, let us begin with acute kidney injury. Question 1. A 72-year-old lady is brought to the ED for lethargy and reduced appetite a few days after enduring a URI. Here are her lab values. Urine sodium will be less than 20 or more than 20. Well, let's take a look at the important lab values. Lethargy, temperature, and hypotension. Fever, lethargy, and hypotension equals sepsis. And what happens in sepsis? Reduced perfusion to the kidneys. That's a consequence of sepsis. And when there's reduced perfusion to the kidneys, that's a pre-renal AKI state. And therefore, sodium will be less than 20. And let's explain why. In pre-renal AKI, the urine sodium is less than 20 because the kidneys recognize the reduced perfusion, activating the renin-angiotensin-aldosterone system. Then, aldosterone acts to increase serum sodium, thereby decreasing urinary sodium. So again, in pre-renal AKI, aldosterone is released, which leads to increased serum sodium. Now this is really important, because in pre-renal AKI, the kidneys are able to do this. They're able to retain sodium, because the tubules themselves, at least at this point in time, are not damaged. This is in contrast to, as we'll see, intrinsic renal AKI. So again, low perfusion, sodium reabsorbed. But what will the osmolality of the urine be? Well, as sodium comes out, water comes along with it, and therefore, urine osmolality will actually be high. So urine will have low sodium, because sodium is reabsorbed, but it will have high osmolality. Question 2. What will appear in her urine? Again, she has a pre-renal AKI. Red blood cell casts, muddy casts, or hyaline casts. So remember, in pre-renal AKI, the tubules are intact, and therefore there will not be any pathologic casts. There will be hyaline casts, which are normally seen in the urine, and so she's happy. Red blood cell casts are a sign of glomerular injury. Muddy casts are a sign of acute tubular necrosis. But hyaline casts are normal. Maybe we'll name the lady in our scene Harleen, because she has hyaline casts. Because again, she had a pre-renal AKI. They're composed of aggregated TH proteins, which we don't care about. These hyaline casts can be elevated in a person with a pre-renal azotemia. So far, what do we have about pre-renal azotemia? Urine sodium, less than 20, because of aldosterone. Urine osmolality, high, because as sodium comes out, water also comes out. And in the urine, we'll see hyaline casts, which are not necessarily pathologic. Question 3. What is her BUN to creatinine ratio? Again, in a pre-renal AKI, more than 20 to 1 or less than 15 to 1. Well, as we recall, there's low perfusion in pre-renal AKI, and sodium is reabsorbed. And BUN is also reabsorbed, primarily in the PCT. Creatinine, however, cannot be reabsorbed. It goes into the toilet. So BUN is being reabsorbed, just like sodium, and creatinine is going out. Therefore, the BUN to creatinine ratio will be elevated. BUN to C, bunk, is elevated. That's why I like to imagine a bunk bed on her head. Bunk bed for BUN to creatinine. And her name was Harleen because she has hyaline casts, i.e. non-pathologic casts. And in the toilet, there's low urine sodium. So the toilet's happy because he doesn't like salt. In pre-renal AKI, sodium is retained. And here is the hippo. I guess Harleen likes hippos. Just kidding, this hippo represents what we're talking about, hypovolemia. that in a hypovolemic state, all these conditions are true. Question 4. What is the treatment for pre-renal azotemia, besides treating the underlying problem, such as antibiotics for pneumonia, crystalloid solution, or amikacin? And the answer is crystalloid solution. Crystalloid solution is just a fancy way of saying saline or lactate ringers. That's what it is. Fluids. Fluids that mimic or closely mimic the body's osmolality. Amikacin, no way Jose, that's an aminoglycoside. That can cause an acute tubular necrosis. That would not treat a pre-renal azotemia. Question 5. An 18-year-old woman is in the ED due to pneumonia. Now she has sepsis, she got IV fluids, vasopressors, and antibiotics, such as gentamicin. She is stabilized, but a few days later, serum creatinine is elevated, and urinalysis shows epithelial cell casts. Epithelial cell casts are another way of saying muddy casts, and they're a sign that the tubes themselves got damaged. Serum creatinine is, of course, elevated because the nephron is damaged, so it's not doing its job properly. And gentamicin is an aminoglycoside, which is probably the cause of the nephron damage here, because aminoglycosides can cause nephrogenic acute tubular necrosis. So the tubules got damaged. Remember, there are two types of acute tubular necrosis, such as ischemic, for example due to an MI, or nephrogenic causes, such as drugs, aminoglycosides, vancomycin, and ethylene glycol, along with contrast. Now, how long does it take for the patient to recover from acute tubular necrosis without considering severe complications? The answer is about 2 to 3 weeks. That's how long it takes for the tubular cells to regenerate. And now that we've spoken about acute tubular necrosis, we can compare pre-renal states, which we've spoken about already, with intrarenal states, such as acute tubular necrosis. And the lab values are the exact opposite. Whereas in pre-renal states, urine sodium is low. In intrarenal states, urine sodium is high because the tubes are damaged and they can't absorb sodium anymore. And if we move down, these are the red blood cell casts, the white ones, the muddy ones, and the fat ones. Question 6. A 37-year-old man comes in, blah, 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 and urine shows white blood cell casts. What is the diagnosis? So white blood cell casts are seen in acute interstitial nephritis. Whereas in glomerular nephritis, we see red blood cell casts. In acute tubular necrosis, we see muddy casts. Eosinophils may also be found in the urine in acute interstitial nephritis, but they're not always found. Now, the same thing, acute interstitial nephritis, would have been the right answer had the question said, a man comes in with a fever, rash, and kidney injury. What is the diagnosis? Acute interstitial nephritis. Acute interstitial nephritis is a hypersensitivity reaction which affects the interstitium and the tubules, and it improves the cessation of the drug. Drugs which can cause an acute interstitial nephritis include penicillin, sulfa drugs, allopurinol, phenytoin, quinolones, and NSAIDs, the same drugs which cause Stevens-Johnson syndrome in addition to lamotrigine. And it makes sense. Both conditions cause a type 4 hypersensitivity reaction. How is acute interstitial nephritis diagnosed? Clinically. But kidney biopsy is the gold standard. We just usually don't need it. How is acute interstitial nephritis treated? Stop the offending agent. And if there's no response, then we give steroids. So far we've discussed tubular diseases. Now let's talk about glomerular diseases. Nephrotic syndrome, which involves loss of protein, and nephritic syndrome, which primarily involves glomerular inflammation. Question 7. Which value is increased in nephrotic syndrome? Albumin, antithrombin, gamma globulins, or lipids? And the answer is lipids are elevated in nephrotic syndrome. Albumin is lost in the urine. Proteinuria. That's the definition of nephrotic syndrome. More than 3.5 grams a day of protein that's lost. And that's why they get edema, because of the low autoclonic pressure. Antithrombin 3, that's what leads to hypercoagulability. And gamma globulins, those are also lost in the urine. That's why patients with nephrotic syndrome are more prone to infections. That's why patients with nephrotic syndrome require pneumococcal vaccinations. Lipids, those will be elevated. And the reason is because the liver produces lipids and cholesterol in response to low circulating proteins. That's why in nephrotic syndrome, patients are more prone to accelerated atherosclerosis because they have so much lipids in their body. They need to be put on statins. Now, how do you minimize proteinuria in nephrotic syndrome? ACE inhibitors. How do you minimize lipids in nephrotic syndrome? Statins. How do you minimize edema in nephrotic syndrome? Loop diuretics. What cheese is made backwards? Edam cheese, right? Because if you spell the letters backwards, Edam cheese, that's just a joke. All right, question 7. A patient with nephrotic syndrome now has flank pain and hematuria. This was most likely caused by, if they have flank pain and hematuria, it's likely caused by a reduced anticoagulant, because now they have a renal vein thrombosis causing the flank pain and hematuria. Hematuria and red blood cell casts in the urine is a sign of nephritic or nephrotic syndrome. So usually this is associated with nephritic syndrome. Here's a cute mnemonic. Nephritic syndrome involves proteinuria, hematuria, azotemia, red blood cell casts, oligoria, and hypertension. And here we just see the differences between nephritic and nephrotic syndrome in a cute little cartoon. I actually put this cola can over here. This cola can reminds us of the cola-colored urine in nephritic syndrome. Question 9. Which type of renal tubular acidosis causes hyperkalemia? 1, 2, 3, or 4? So if you don't know renal tubular acidosis well, welcome to the club. As for the answer, it's not type 3, because there is no type 3. At least not that I'm aware of. It's type 4. Here's a cute little mnemonic from Dirty Medicine. 214, low, more. In type 2 it will be low, in type 1 it will be low, but in type 4, potassium will be elevated. If on test day there's hyperkalemia, you know it's type 4. If on test day there are kidney stones, or the urine pH is elevated, or there's calcium, you know it's type 1. Question 10. When a person has a low blood volume, for example due to vomiting, what will happen to the nephron efferent arteriole? Well, remember, angiotensin II has various functions. And when a person has a low blood volume, angiotensin II does its job. For example, it constricts the efferent arteriole. So therefore, since we have low blood volume in our question, the arteriole will constrict. Remember, angiotensin I is converted to angiotensin II through ACE, and angiotensin I itself used to be angiotensinogen until renin came along. That's what renin does. Question 11. Does metformin cause kidney damage? And the answer is no. Metformin does not cause kidney damage, it just increases lactic acidosis. That's why we hold it in hospitalized patients, especially in a patient with renal insufficiency, because we don't want lactic acidosis to build up, which can increase creatinine, and the answer is BPH. Fiber might be able to reduce creatinine, but BPH could lead to an increase in creatinine. Here we see the BPH causing an obstructive uropathy. This leads to a slow rising creatinine. But if you see a question of the person who has BPH and they have proteinuria, you know it's probably not because of the obstruction, because BPH cannot lead to an increase in proteinuria. Question 10. I'm not sure how we got to question 10. We've already done question 12. But anyway, secondary nocturnal enuresis in children is usually developmental or due to some cause, and the answer is it's due to some medical or psychological condition. Remember, primary means since birth, and secondary means they've gone at least 6 months with bladder control. So secondary enuresis would be due to a medical or psychological condition, whereas primary would be developmental. In both cases, the child is over 5. In both cases, we get a urinalysis to assess, for example, UTI or proteinuria. And remember, newborns are supposed to have at least 1 wet diaper per day of life. So if a neonate has a single wet diaper in the first 2 days of life, we need to get, for example, a renal and bladder ultrasound to assess for any congenital anomalies. Question 11. What is the main cause of death in patients with scleroderma? Renal failure or lung disease? And the answer is lung disease. It used to be renal failure before the 1980s, but now it's lung disease. And what is the mechanism of sclerodermal renal crisis? It occurs due to collagen deposition and endothelial injury in the renal blood vessels. Question 12. Splanchnic vasodilation that leads to kidney injury which does not improve with fluids. This is hepatorenal syndrome, a very life-threatening condition. What is the treatment for hepatorenal syndrome? Well, really, it's liver transplant. But until then, albumin and renal vasoconstrictors, because again, the problem is vasodilation. And you can just take a look at my video online of hepatorenal syndrome. Question 13. A 48-year-old woman with a recent UTI now has right-sided flank pain fever, but no bacteria or red blood cells are found. What is the diagnosis? So this is renal abscess. Remember, renal abscess shows up after UTI with flank pain and fever. We may or may not see bacteriuria or proteinuria. And here we just have a picture of the renal abscess. Question 14. A 47-year-old woman got a renal transplant, now has decreased renal function. Her medications include prednisone, tacrolimus, among others. What caused the kidney injury? So remember, tacrolimus is nephrotoxic, and it causes a pre-renal condition. That is, calcineurin inhibitors cause vasoconstriction. The AKI is through a pre-renal mechanism. It's quite interesting. Tacrolimus is used in kidney transplant to prevent rejection, but it's nephrogenic. And note, diuretics such as furosemide also lead to pre-renal azotemia, but through a different mechanism. That is, they lower blood volume, so there's lower cardiac output, so there's lower perfusion to the kidney. Question 15. How does cardiorenal syndrome damage the kidneys? So this is not hepatorenal, this is cardiorenal. And in cardiorenal syndrome, there's increased central venous pressure, heart failure, leading to volume overload, and venous pressure and congestion, damaging the kidneys. Question 16. What is the mechanism of NSAID-induced kidney injury? So NSAIDs lead to either interstitial inflammation, as we mentioned before in acute interstitial nephritis, but we usually refer to the prostaglandin inhibition. By inhibiting the prostaglandins which dilate the afferent arteriole, NSAIDs effectively constrict the afferent. And here we just have a comparison of NSAIDs and ACEs and ARBs. Remember, NSAIDs constrict the afferent, and ACE inhibitors effectively dilate the efferent. Question 17. 50% of patients with rhabdo develop acute kidney injury. 50%. That's why we have to check their CK levels. And the mechanism of injury is that myoglobin causes damage to the kidney tubules. Question 18. How to prevent contrast-induced kidney injury? And the answer is not by holding with metformin. Remember, metformin is not nephrogenic. It's by giving contrast with fluid. For example, 0.9% saline. We also want to give the lowest possible dose of contrast possible. Question 19. What study should be done in a patient diagnosed with membranous nephropathy? And the answer is hepatitis B serology, because membranous nephropathy is associated with hepatitis B as well as C. I like this mnemonic I made over here. Another pharaoh. Remember the froggy reminds me of membranous nephropathy. Pharaoh here is really scared because of the froggy. He had been in the middle of putting a deposit near a subway. So subway deposit for sub-epithelial deposit or deposition. And it's associated with Hep B and C because the story of Pharaoh occurred in BC, before the year 0. And it's also associated with SLE, malignancies, and NSAIDs. Question 20. What type of casts are seen in renal disease associated with Henoch-Schönlein purpura? Remember, IgA nephropathy is associated with Henoch-Schönlein. Some consider them different manifestations of the same disease. But anyway, they have red blood cell casts because it's a glomerulonephritis. Remember, IgA deposits in the mesangium leading to inflammation, but we do not see any changes in complement because complement is not involved in IgA nephropathy. And in Henoch-Schönlein, there's a low-range proteinuria. And I just wrote a reminder over here, not that this is a new question, but chronic HCV can also cause mixed cryoglobulinemia, which is a small vessel vasculitis that presents with palpable purpura, glomerulonephritis, joint pain, and peripheral neuropathy. Here's the real question 21. A 6-year-old boy comes in with hematuria and C3 levels that are low. Protein is 1+. What is the diagnosis? So here we see C3 levels are low, so we know it's not IgA nephropathy. This is post-strep glomerulonephritis. In focal segmental glomerulosclerosis, we would see protein 3+ or 4+ in the nephrotic range. Again, in IgA nephropathy, C3 levels would be normal. Post-strep glomerulonephritis, this involves immune complex deposition, so C3 levels will be low. C4 levels may also be low. And remember, if you see a kid with periorbital or general edema with cola-colored urine a little bit after having group A strep, think of post-strep glomerulonephritis. And here we just compare IgA nephropathy and post-strep glomerulonephritis. Remember, by the way, both conditions may be asymptomatic, but in both, serum creatinine is elevated. Question 22. Creatinine increases in pregnancy or diabetic kidney disease? And the answer is in diabetic kidney disease, because in pregnancy it actually goes down due to hyperfiltration. So if you have a pregnant patient with elevated creatinine, start thinking about kidney disease. For example, diabetes, because pregnancy can actually worsen a diabetic nephropathy. Besides ACE inhibitors and loop diuretics, how is an obese patient with focal segmental glomerulosclerosis managed? With steroids or weight loss? And the answer is with weight loss. Steroids are only helpful in primary focal segmental glomerulonephritis, and weight loss is helpful in secondary, for example due to heroin, HIV, or infection. So I mentioned obese in our question, which on exam day is associated with secondary focal segmental glomerulosclerosis. I have another question 22. Glomerulonephritis and low complement and positive serum cryoglobulins. This is seen in membranoproliferative glomerulonephritis. In lupus nephritis, we see a positive ANA, which is the most sensitive test, or anti-dsDNA or anti-Smith, which are more specific but not so sensitive. Cytopenia is not just associated with malignancy, it's also seen in conditions, for example, in lupus. And here we just have the thick capillary wall seen in membranoproliferative glomerulonephritis. By the way, both focal segmental glomerulosclerosis and minimal change disease both involve podocyte effacement. So if you see podocyte effacement on exam day, think of these two conditions. Minimal change disease more often in children. Question 23. A 15-year-old boy has hematuria, dysuria, and pyuria, i.e. white blood cells in the urine, but no flank pain. What's the next step? So we want to give antibiotics because we're dealing with a UTI. Renal ultrasound, that would be for something like a stone, which would cause pain. Question 24. A 3-year-old girl has few-day history of periorbital edema and labs show 4+ proteinuria. So we know this is not post-strep glomerulonephritis. So what's the next step? So here we want to give steroids because it's most likely minimal change disease which shows up in children, and steroids are very effective for this condition, but the condition does recur. Question 25. How do you treat uric acid kidney stones? And the answer is increase the pH of the urine. For example, with potassium citrate, this causes uric acid to become more soluble and promotes stone dissolution. Furosemide doesn't treat uric acid stones. It can contribute to the development of calcium stones because furosemide dumps calcium into the nephron. And here we just have associations of the various stones. Definitely remember this because this is super high yield. For example, calcium oxalate stones are seen especially in Crohn's patients. Because in Crohn's patients, they can't reabsorb fat. So the fat binds with calcium, so oxalate is reabsorbed and then dumped into the kidney, leading to calcium oxalate stones. The treatment for calcium oxalate stones are thiazides. Of course, we also give hydration. Ammonium magnesium phosphate, think of the gram-negative bugs, Proteus and Klebsiella. They can cause Staghorn colliculus, which has rapid growth, and it's associated with UTIs. Treatment of ammonium magnesium phosphate stones are surgical removal of the stone, antibiotics, and possible nephrectomy. Uric acid stones, remember, these are the ones not seen on x-ray because they're radiolucent. And as we mentioned, treatment is potassium citrate, and cysteine stones are rare. They're most common in children, and they could also present with stag or caliculi, and treatment is with hydration and alkalization of the urine. Question 26. Kidney and bone cysts are seen in amyloidosis due to dialysis, as the beta-2 microglobulin cannot be adequately eliminated, resulting in carpal tunnel syndrome, shoulder pain, and bone cysts. And these could actually result in fracture. Question 27. Elevated creatinine, small kidneys, no red blood cells, trace proteinuria is due to high blood pressure. In high blood pressure, there is chronic stress on the renal vasculature, so there's ischemia and fibrosis. As opposed to an amyloidosis, we see large kidneys and nephrotic syndrome, i.e. lots of proteinuria. Question 28. AA amyloidosis in a patient with, for example, rheumatoid arthritis, most commonly manifests with renal problems. That's why we're talking about in the renal section. 90% of patients with AA amyloidosis have renal problems, and it's diagnosed with biopsy, which shows amorphous material on staining with Congo red. Is it just me, or do you think of this guy when you think of Congo red? Maybe it's just me. But anyway, Congo red, amyloidosis, renal problems. Versus AL amyloidosis seen in multiple myeloma. Question 29. Sickle cell trait does which of the following? All of the above. It provides malaria protection, confers an increased risk to DVT, and confers an increased risk to renal papillary necrosis. And this happens especially under physiological stress such as dehydration and acidosis, because sickling can occur. Question 30. Atherosclerosis and severe hypertension and pulmonary edema, for example with Crackle's JVD but no low extremity edema, so we know we're dealing with a pulmonary edema. This is due to renal artery stenosis. You get a Doppler ultrasound. And by the way, just a reminder that this condition may be seen a few years after a patient's had a kidney transplant, that the renal artery from the kidney transplant could lead to a stenosis. As I mentioned already, renal artery stenosis causes resistant hypertension. And which kidney releases renin? Only the kidney involved. Only the kidney that has the stenosis. If it's bilateral, it will be bilateral. Question 31. A patient comes in with severe flank pain. CT reveals a 4mm stone. There are no signs of infection or impaired kidney function. What's the next step? And the answer is hydration and a strainer. What I mean by a strainer is like a tea strainer to catch the stone so we can assess the stone composition. Hospitalization is not necessary because most stones pass when they're less than 5mm. Question 32. What is seen in chronic renal failure? And the answer is we see easy bruising. The mechanism is as follows. As urea rises, arginine and its precursors are shunted to produce nitric oxide. Nitric oxide levels build up, which disrupts primary hemostasis, so we don't have proper platelets, and this is what's seen in chronic renal failure. We don't need to know this mechanism, just recognize that in chronic renal failure, there may be easy bruising. But there's not hypercalcemia and hypokalemia, we have the opposite. We have hyperkalemia because we can't excrete potassium. Question 33. Kidney failure leads to bone damage due to all of the above. Elevated PTH levels, because PTH is released in response to low calcium, and PTH leads to bone resorption. As we mentioned, we have low vitamin D levels, so we can't mineralize new bone, and metabolic acidosis produces an environment of low pH, and that inhibits bone mineralization. So if you see a patient with osteoporosis come in with a history of CKD, the first thing to order is a PTH level. Maybe there's low calcium leading to elevated PTH, and that leads to bone resorption. Question 34. Sudden death in these patients, what do we see? Polycystic kidney disease is from cerebral aneurysm or subarachnoid hemorrhage. Now, how do you treat autosomal dominant polycystic kidney disease hypertension? Because these patients have hypertension, and you treat it with ACE inhibitors. And the reason is because in autosomal dominant polycystic kidney disease, what happens is there's a localized ischemia secondary to cyst enlargement, and this local ischemia leads to an elevated RAS. That's why we give ACE inhibitors to depress or suppress the RAS system. The most common cause of death in these patients is not cerebral aneurysm, it's renal failure. And we treat this with tolvaptan. This delays progression, but it doesn't stop it completely, and that's why these patients often need long-term dialysis. Question 36. Patients in their 30s with hypertension, hematuria, and flank pain. This is polycystic kidney disease. Remember, patients often present in their 30s and 40s with polycystic kidney disease. Question 37. Kidney disease and mitral valve prolapse. This is polycystic kidney disease. Remember, in this condition, they're floppy everywhere. In the kidneys, in the heart, in the liver, leading to cysts. In the intestines, that's why they get diverticulitis. And brain vessels, that's why they get the cerebral aneurysms. Question 38. What is very concerning in a patient with kidney stone? And the answer is fever and CVA. Fever and CVA tenderness are signs of infection. For example, pyelonephritis. And so it can progress to sepsis. Dilation of the ureter is not concerning because that's seen with all stones. Question 39. What gynecologic condition can result in cyclic hematuria? And the answer is endometriosis, because the implants can be in the bladder, leading to cyclic hematuria. They get it when they have their periods. Question 40. Stones that are between 5mm and 10mm are treated with Alpha antagonists such as tamsulosin, because the blocking alpha leads to smooth muscle relaxation, and so the stone passes. Surgery is when it's 10 or more. Some say 7 or 8 or more, but the point is, for the purposes of exams, if it's 10 or more, that's when we go with surgery. Question 41, which does not prevent calcium oxalate kidney stones? And the answer is protein. Protein actually increases the risk of a stone, because there's increased oxalate, and oxalate binds with calcium to produce the stone. And you could take a look at the other conditions that we have over here, why they could prevent calcium oxalate kidney stones. Question 42. What are the most common bugs implicated in dialysis-related infections? Staph aureus and Staph epidermidis, seen in both hemodialysis and peritonitis related to peritoneal dialysis. So in both forms of dialysis, we have these bugs. We gram stain and culture the peritoneal fluid. Question 43. A 20-year-old woman with recurrent headaches, hypertension, and renal artery stenosis. This is fibromuscular dysplasia. Where do you see this picture? It's always this picture when it comes to fibromuscular dysplasia, where we see the string of beads appearance inside the renal vasculature. This is kind of like what we see in primary sclerosing cholangitis, what we see in the biliary ducts. This is what we see in fibromuscular dysplasia by the renal vasculature. All right? The headaches in this condition are due to the internal carotid stenosis. First-line hypertensives for fibromuscular dysplasia are ACEs and ARBs. Definitive treatment is with percutaneous transluminal angioplasty or surgery. Question 44. What is the management for simple renal cysts? Reassurance. Concerns for malignancy are when there are irregular walls, multilocular, contrast enhancement, and they cause pain or hematuria. Question 45. Patients such as a baby with but if the reflux is only mild, antibiotics may not even be needed. Question 46. A patient who is older than 50, unintentional weight loss, smoking, hard flank mass, we know this. This is renal cell carcinoma, but the mass may be found incidentally, for example, in an asymptomatic patient. Don't think that in renal cell carcinoma there's always flank pain or that there's always hematuria. Question 47. Besides behavior modification, what's the best treatment for nocturnal aneurysms? The answer is desmopressin, not imobrin. That is a TCA, a tricyclic antidepressant that has lots of side effects, so it's of course not first line. For example, it could cause cardiotoxicity. Question 48. What's the test for a patient with suspected urethral injury? The answer is retrograde urethropography. It involves an x-ray of the urethral tract and extravasation of contrast denotes urethral injury. Question 49. Flank pain and wedge-shaped cortical infarction of CAT scan? That's a renal infarction. It has a wedge shape. Remember, ischemia produces wedge shape, just like it does in the lungs in pulmonary embolism. And for example, a renal infarction could be due to an infectious endocarditis. Question 50. Bladder cancer screening is never, ever, even though it's at increased risk. Question 51. First step in suspected bladder cancer is cystoscopy. This allows direct visualization, I meant to write visualization of the bladder wall, and we biopsy anything suspicious. We get a CAT scan just for staging. Question 52. The most common cause of bladder distension in newborn boys is posterior urethral valves. This can lead to a Potter sequence when in utero we get a renal and bladder ultrasound and a cystourethography. Question 53. Renal cell carcinoma and hemangioblastomas, we know this, von Hippel-Lindau. It's an autosomal dominant condition where there's a VHL tumor on gene 3 leading to hemangioblastomas, pheochromocytomas, renal cell carcinoma, and we treat it with tumor resection. Question 54. The most common renal malignancy in children is Wilms tumor, associated with Wagger and with BWS. In Wagger, we see Wilms aniridia, GU, and mental retardation, now known as intellectual disability. Question 56. An adolescent who develops a varicocele should be reassured. Generally, adolescents should be reassured because it's probably primary, and we can test it out if it decompresses when supine, as opposed to in children, varicoceles are concerning, usually secondary, and it persists in the supine position, so we get an abdominal ultrasound. 57. A child with hearing loss and hematuria, Alport syndrome. Alport syndrome involves splitting of the glomerular basement membrane, and it's an X-linked disorder. 57. Another 57. A child with recurrent episodes of simple cystitis with no fever, flank pain may have constipation. Recurrent UTI would cause pyelonephritis, not simple cystitis. Constipation can lead to cystitis. And the treatment is stop holding it in, and we may provide the child with laxatives. 58. Fibrotic narrowing of the urethra, urethral stricture. Can be idiopathic or complex trauma, and we treat with dilation or with surgery. 59. First-line treatment for stress urinary incontinence is Kegels. I just made up that word. There's no such word Kegels. It's Kegel exercises. Kegel exercises is first line for stress urinary incontinence, and if the Kegels don't work, we may give a pessary. And here we just compare the various types of urinary incontinence. And I have a little mnemonic in case you have a hard time. Here we have the bladder who's very stressed. He's very stressed. And he has his cake kugel. I give him the cake kugel to make him happy. Cake kugel for Kegel. Here we have something going on that's very urgency or incontinence, and there's this rocket flying away because in urgency incontinence, there's this sudden, overwhelming need to pee. And what happens is there's this ox over here trying to stop the rocket. The ox, oxybutynin. This ox over here actually has a mustache with an ant on it for antimuscarinic, because oxybutynin is an antimuscarinic. So again, the ox that's an antimuscarinic for oxybutynin is trying to stop the urgent rocket flying away for urgency incontinence. And here we have a lady who has overflow incontinence. We see it's overflowing. So her friend Beth gives her a call for bethenacol. That bethenacol is used to treat overflow incontinence. Question 60, what's the treatment for UTI in children? And the answer is, we need E. coli coverage. And you can take a look at the other choices over here. Question 61, anticholinergic-induced urinary retention is treated with drug cessation reduction and intermittent catheterization. For example, in a patient taking amitriptyline or diphenhydramine and they get urinary retention, give them intermittent catheterization. 62, lithium-induced nephron damage leads to low urine osmolality that does not improve with desmopressin. Remember, if it improves with desmopressin, we know it's central diabetes insipidus, but in nephrogenic, it does not improve with desmopressin. And high urine osmolality, that would be seen in polydipsia. Question 63, thiazides lead to low levels of sodium and potassium. That is, thiazides increase renal excretion of sodium and potassium. Also, we see low magnesium. Question 64, which tubulopathy is like being on a thiazide all the time? That is, they get hypokalemia and hyponatremia and hypomagnesemia and low blood pressure. And the answer is Gittelman syndrome. I like to imagine the gentleman wearing a tie. Gentleman for Gittelman and tie for thiazides. You could think of Gittelman syndrome as being like a chronic thiazide state. And we can contrast Gittelman with Liddell. In Liddell, there's high blood pressure. Now, I like this because this is actually an ABC order. Barter, Gittelman, and Liddell. Meaning, Barter affects the thick ascending limb, Gittelman affects the distal tubule, and Liddell affects the collecting duct. And all cause hypokalemia. My mnemonic is, bagels are low in potassium. Bagels for Barter, Gittelman, and Liddell lead to hypokalemia. Question 65. Bulimia volume depletion is treated with normal saline. Fludrocortisone is for primary adrenal insufficiency. Question 66. Which electrolyte abnormality leads to peak T waves and shortened QT? And the answer is, if you ever see the shortened QT, think of the hypers. And here it's hyperkalemia. Hyperkalemia and hypercalcemia both lead to short QT. As opposed to hypocalcemia and hypokalemia, they lead to prolonged QT. Question 67. Severe hypercalcemia is treated with hydration and calcitonin. And of course not thiazides. That would worsen hypercalcemia because it's calcium sparing. Question 68. Lab values in a patient show potassium levels 8, which is really high, and EKG shows peaked T waves. So we see EKG changes associated with hyperkalemia. What's the next step? We don't repeat the potassium levels because we've already confirmed that there's a symptomatic patient here. So we give calcium gluconate. Calcium protects the cardiac myocytes, and we follow up with insulin and glucose. 69. Rapid correction of hyponatremia can result in osmotic demyelination. I've never heard a medical student talk about osmotic demyelination or cerebral edema without using the following poem. From low to high, your pons will die. From high to low, your brain will blow. Question 70. CKD hyperkalemia management includes zirconium or ACE inhibitors, and the answer is zirconium. Kayexalate falling out of favor. Now it's zirconium and patirimer. The way zirconium works is that it exchanges potassium for sodium. That's why I like to spell it potassium sodium zirconium. Zirconium exchanges potassium for sodium, so potassium dumps into the nephron and sodium is reabsorbed. Again, also patirimer, sodium for calcium. Question 71. Tinnitus, fever, and tachypnea. So this is seen in aspirin overdose. What metabolic status? Mixed primary respiratory alkalosis and primary metabolic acidosis, often showing normal pH. 72. Hypernatremia can be caused by all of these: diuresis, dehydration, diabetes insipidus, diarrhea, disease, all cause diapernatremia. Question 73. Hyponatremia is defined as serum sodium less than 135. It may be asymptomatic. Patients may have confusion, muscle cramps, or nausea, and the first step is the serum osmolality. And here we just have workup for hyponatremia. For the purpose of exams, we focus on this one over here very often. That in hypotonic, hyponatremia, and the patient is euvolemic. So we have to differentiate SIADH from polydipsia. What conditions can cause hypercalcemia? And the answer is all of these. Hyperparathyroidism, sarcoidosis, thiazides, all of these. And malignancy as well as squamous cell carcinoma and multiple myeloma. Another question 74. A patient develops cramps and tetany after thyroidectomy. What happened? Parathyroidectomy. Remember, parathyroidectomy can lead to a hypocalcemic state. Vision loss and optic disc hyperemia is seen in methanol toxicity. Ethylene glycol leads to stones. Methanol toxicity leads to vision changes. Question 76. Kidney disease and asthma. Churg-Strauss syndrome. The other two conditions involve kidney and lung, but in Wegener's, we also see sinus. Question 77. Man in his 20s has glomerular nephritis and pulmonary hemorrhage. This is Goodpasture syndrome, which often shows up in men in their 20s. There's no upper respiratory involvement, and this is a very severe condition. Let's end off with pure urology stuff. Fever and tender boggy prostate, that's prostatitis. Treatment includes ciprofloxacin, PSMX, and doxycycline. Hydroceles typically resolve in 6 to 12 months. If not, what's the treatment? We take it out with surgery due to the risk of inguinal hernia. Remember, hydroceles transluminate, varicoceles do not. Testicular torsion. Should you first try to manually correct? Only if it will not delay surgery or surgery is unavailable. Remember, this is a huge emergency. You have to do detorsion in 6 hours or else. 81. Erection is mediated by parasympathetics. Remember, point and shoot. 82. Nitrates cannot be combined with sildenafil, PGE5 inhibitors. They can dangerously lower blood pressure and affect the heart. 83. Best initial treatment for BPH is blockers, such as tamsulosin and terazosin. They're great if the patient is also hypertensive. What's the next best step? 5-alpha reductase inhibitors, such as finasteride. Severe, transurethral resection or surgery, take the prostate out. By the way, which zone is affected in BPH? The central zone, and that's why it cannot be felt on DRE. 84. Elevated PSA is seen in all of these prostate conditions. And as we know, it's controversial as a screening tool, but it can detect a prostate carcinoma recurrence. 85. The most common malignancy in men 15 to 34 years of age is testicular cancer. Question 85. The most common malignancy in men 15 to 34 is testicular cancer. Another 85. Orchiopexy should be done by 6 months. Remember, inguinal hernia by 5 years, but orchiopexy by 6 months. I like to call it orchio-6-monksy. Orchio-6-monksy reminds me that orchiopexy should be done by 6. Question 86. Posterior testicular pain and swelling that improves with testicular elevation is seen in epididymitis. All right, and most common is chlamydia and Neisseria if the patient is less than 35, and E. coli if they're more than 35. Less than 35, we give ceftriaxone and doxycycline. Question 87, if a wrestler has infertility and strong muscles, what lab values are low? Well, he's taking anabolic steroids, so GnRH, LH, and FSH low because the steroids inhibit GnRH release from the hypothalamus. 88, after injection of phenylephrine, a man's priapism improves. What's the next step? We want to get a CBC to assess for something like sickle cell that predisposes them to this condition. But again, priapism can be idiopathic. 89, cystic fibrosis leads to infertility due to absence of vas deferens. Flagellum motility, that would be seen in Cartaginer syndrome. All right, vas deferens may be the only feature in a patient with mild cystic fibrosis. Question 90, sildenafil can lead to all of these: priapism, flushing, blue discoloration of vision, optic neuropathy, as well as headaches. And by the way, you don't take sildenafil with nitrates, or I didn't mention this before, alpha-1 blockers, such as dexazocin. 90, which is used to treat premature ejaculation. Paroxetine, not oral lidocaine, but topical lidocaine. 92, after stabilization, burn patients require aggressive fluids and urinary catheterization because they can't pee. We need to get the pee out. Question 93, prostate tenderness, recurrent UTI, painful ejaculation. This is chronic bacterial prostatitis. All right, we treat with 6 weeks, for example, of a fluoroquinolone. 94, penile pain, curvature, and trouble with intercourse. This is Peyronie's disease. I think that's how you pronounce it. Peyronie's disease. And we treat with pentoxifilline and collagenase injections and surgery if it's refractory. 95, testicular mass, gynecomastia, and elevated estrogen. This is seen in Leydig cell tumors because of the increased estrogen levels. They get gynecomastia. All right, this is not seen in, for example, Sertoli. 96, a common germ cell tumor that presents with a painless unilateral testicular mass, but usually no elevated lab values such as beta-HCG and AFP. This is the seminoma, the most common of all the testicular cancers. All right, in the non-seminomas, we have elevated lab values. For example, in beta-HCG, this is seen in choriocarcinoma. In AFP, that's the yolk sac tumors. 99, what's the greatest risk factor for prostate cancer? Advanced age, especially if they're over 70. And 100, a boy comes in with suspected testicular torsion, but it's not clear. What's the next step? We want to get a Doppler ultrasound of the scrotum to assess. All right, that's the end of this video. I really hope you enjoyed. Stay tuned for the next video, and take care.